السلام عليكم. دكتور محمد. Hello.
أنا معك.
أيوة. I think you can start now, please. السلام عليكم ورحمة الله وبركاته. Welcome everyone who join us today with this beautiful night with a distinguished speaker from Sultan Qaboos University Hospital, Dr. Mohammed Al Mutani, a consultant lower limb surgeon, and with the interesting topic. Dr. Mohammed, thank you for accepting our invitation from Orthopeadic Society of Oman, and we are delighted you are with us. The floor is for you. You can start.
Thank you very much, Dr. Saleh. May I ask everyone just to keep your mics muted, please, because there's some noise at the background I can hear. Secondly, thank you very much for joining us for this evening. The topic is about meniscal root tear, and before I start on this, my experience on this was really since I joined, and the person who enlightened me about this condition and this pathology was my mentor, Dr. Sultan Qaboos. And because during my training, I remember seeing only one case of root tear and was traumatic. And but here, it's fairly common that we see meniscal root tear. Okay, so the outline of this talk would be starting with a case example and then moving on to some basic science of meniscus. Then we will see how do they present, and then talk about the radiology findings, specifically the MRI scan, and then the outcome of this problem if treated or untreated, and then how to deal with it. And also finally, I'll just show you a video of how we managed the case that we are discussing today. Okay, so this is a 37 years old lady who presented with 2 years history of posteromedial knee pain and inability to pray on the floor. There was no history of trauma. Past medical history is unremarkable. Examination is showing normal alignment of the lower limbs, no effusion. There was joint line tenderness medially, McMurray's was positive. The knee was stable, and also to note that she was overweight. She was seen elsewhere, and she was sent for an MR scan, and the MR scan came back as there's a ganglion cyst in the ACL coming from its proximal fibers. The rest of the examination was unremarkable, apart from the Baker's cyst as well. Here I have highlighted their comment on the menisci as normal signal intensity, and this is a report by a radiologist who commonly see images and look into scans. Now I'll just run through. I have downloaded the scans here so that we can see how we interpret or look into these type of pathology. So here you can see on the coronal images, there is the meniscal extrusion, very obvious in there. And as you go backwards, you can see a radial tear at the near the insertion of the posterior medial meniscus root. On the axial views, we will see the radial tear very clear. If we stop there, that is the radial tear, very obvious, very close to the insertion within 1 centimeter of the insertion of the medial meniscal root. Okay, so these are just to highlight the findings in this case, and also not to forget that she had like a ganglion cyst or a cyst around the ACL. So this is the finding, the arthroscopic findings, and this is the repair at the end. So I will show you the video also on the procedure, but let's just go through the pathology here, which is the meniscal root tear, basically defined as an avulsion of the insertion of the medial of the meniscus, basically not the medial, or it can be medial or lateral, but of the meniscus attachment, or a complete radial tear within 1 centimeter of the meniscal insertion. And this can be anterior, posterior, medial meniscus, lateral meniscus, but the most common one is the posterior root of the medial meniscus. So if we come to the meniscus and talk about its anatomy and histology, it is basically a fibrocartilaginous structure, which is semicircular, that is formed by extracellular matrix, basically, which are water, collagen, proteoglycans, and other non-collagenous proteins and cells. Now, the majority of the component of the composition of this is water, 70%, and about 20% is collagen type 1, with some contribution of other types of collagen. And the orientation of these collagens is circumferentially, obliquely. They are arranged in a way that they can convert a compressive forces into a circumferential or hoop stresses. And for this to function, you have to have a stable meniscus on either end, which is anchored to the bone. Okay, another important structure is the proteoglycans. And these proteoglycans, as shown here in this image, they are large molecules which are negatively charged. They attract water. That's why we see a lot of the water constitutes a lot in the cartilage in general, because of this structure, and because they are negatively charged, they repel each other, and that's why they can accommodate high compressive forces without any major issues, and that's why these structures are essential for the integrity of the meniscus. So the meniscus functions as load transmission, shock absorption, helps in stability, nutrition, and lubrication of the joint, and proprioception as well. Another important thing that really relates to this talk is it decreases the contact stresses and increases the contact area and the congruity of the knee. Moving to the kinematic of the meniscus. Now, in general, we know that the lateral meniscus moves more compared to the medial meniscus. And actually, the amount of movement in the lateral meniscus, it almost like jumps out of its position in the posterior condyle, about 1 centimeter goes off. Whereas we know that the medial meniscus is quite attached to the capsule and the movement is minimal, and the posterior excursion is about 3.2 millimeter and does not go beyond 2 to 3 millimeter radial displacement in the non-weight bearing status. Now, if you get a radial or a posterior medial meniscus root, then the movement is significant, is about, in this paper, about like 9 millimeter. And looking at this image, for example, this shows you the top ones here is a normal intact root of the meniscus, medial meniscus here. And you can see that there is some excursion and deep flexion moving backwards, but it does not really go beyond this level, okay? Whereas, look at the second images here on the bottom, we can see in 90 degrees of flexion. So this is deep flexion here on top. This is only 90 degrees in this paper. And look at the meniscus, how much it has extruded. And this caused impingement, and that's why our patient was not able to load a prey on the floor because of the meniscal impingement posteriorly. So meniscal root tear is, it can occur as a traumatic event, as a result of traumatic event, but majority affects the posterior, the medial meniscus posterior root, and about 70%, and affects the degenerative knees mostly. And the incidence of the medial meniscus root tear reported to varies between 10 to 20% of the medial meniscal tears. And this is due to the fact that it's the least mobile area in the meniscus, and that's why we get the posterior horn in general having pathologies more than the anterior portion of the meniscus. So presentation, how do they present to us? Normally, you will see more females than males between the 4th and 5th decades, but you can see them at any age. It's just you need to be suspicious about it and think about it and investigate it. Overweight and varus malalignment are risk factors. The typical history, they will tell you that I was just standing or walking my normal walk and suddenly I felt something happening in my knee, and since then my knee is painful, or I cannot pray on the floor. Okay, there is no significant trauma normally. Okay, now occupational factors play a role. Now this is an interesting paper from India looking at the squat winnowing, where they do the rice and the wheat. They sit on this position for quite a long time, and they found that these females come with meniscal posterior horn of the medial meniscus pathology with tears. They did not mention root. They were talking about the posterior horn tears in this paper, but was common in them, non-athletic, because of their occupation. And that also probably would highlight our issues here in our population, the type of position that we adapt, sitting on the floor, crossing our legs long period of time. All of these are probably contributing to the fact that this pathology is becoming more and more evident. So on examination, you'll have to assess full examination. Basically, you will have to assess the alignment. They can present with effusion, of course. Joint line tenderness is positive normally, and McMurray's test is also positive. But remember, any patient who comes to you, you'll have to assess them fully and look for any other associated pathologies. Laprade has classified this into different classification here based on the extent of the tear. And so type 1 is just partial tear, complete radial tear at the root, and complete radial tear with bucket handle tear as associated with it, or an oblique tear, or an avulsion. Okay, but basically you will have to address this. Is just for like really academic reason. Does it guide your management or not? I doubt that. If you can repair it, you will always go and repair. This is all arthroscopic assessment, and you decide your management. So after the examination, you will request an MR scan, and the MR scan, you'll be looking into the typical features of the radial tear within the insertion, within 1 centimeter of the insertion of the meniscal root. So most of these cases are posterior medial meniscus root tears. As you can see, there is extrusion here and the radial tear at the back, okay? And here in the sagittal views, you look for the ghost sign. Basically, suddenly you'll feel that the posterior disappears there. So that's a ghost sign. Let's go back again to that. I'll show you in these images here, probably will be clearer. So the ghost sign, basically, you see the posterior horn of the medial meniscus suddenly was there and then suddenly you don't see it. That's the ghost sign while you're still seeing the anterior horn. And on the coronal images, you see the radial tear very clear, and also the medial meniscus extrusion more than 3 millimeters. And on the axial view, you see a very clear radial tear. Remember, you don't have to have a degenerate tear, even traumatic injuries like PCL tear. You can still have root pathologies like this one is displaced, and you can see the medial meniscus extruded. Here you can see that the PCL is gone and the medial meniscus root tear is there. So when you address the PCL, you'll have also to look into assessment of the menisci as well, and the entire joint for that matter. So why is it important to recognize this and deal with it quickly? Because of the contact stresses is significantly increased with root tear. Now, this is a paper, a biomechanical paper, looking at cadaveric specimens of root tears and repair, and also total meniscectomies. So number one is an intact meniscus. Number two, this is after repairing the meniscus. You can see that there's like really the contact stresses are minimal. Whereas with root tear, you can see how much of load, and this is the intensity of the color matters rather than the area itself. Okay, so between the root tear and the total meniscectomy, almost they are the same in terms of intensity of stress, and that's why a root tear is equivalent of a total meniscectomy, and that's why you have to address it like really promptly, and you address this pathology quickly and repair it to reduce the stress, the contact stresses, and also this will help reducing the progression of osteoarthritis. Now, this is why we need to move to repair this, because this is a case example by published in this paper, where a progression from a root tear to a partial knee within 1 year only, you can see how bad it is. So the progression of osteoarthritis is quite fast. And other papers have shown that they actually over 5 years, they quickly progress. And that's why and probably this is reflected in our practice, where we see a lot of medial compartment OA in the ladies, like towards their end of 50s or probably early 50s sometimes. So do we repair all meniscal root tears? Of course, there will be limitations to this, but advanced OA changes, you don't need to repair the root. Old age, again, this is written in the literature, you don't do root repair, but we look into the physiology or the physiological age of that joint. If the joint, for example, is very well, like minimal changes, arthritic changes, then why not go ahead and repair it, okay? And even sometimes in arthritic knees, where there is significant mechanical pain, they get some benefit out of this intervention. So this is another case example just to show you that they can present at any age, and it's not always female. So this is a 58 years old. Now, once you see these images, you will think that this patient has presented with a problem of the right knee. But he had meniscal pathology in the right knee, and he had arthroscopic intervention in the past, and he has got arthritis in the right knee. That is not causing him a lot of issues, but he presented with the left knee, significant pain. And as soon as you see the knee where the joint line, the joint space is maintained, always think, could this be something else? Because the other differential diagnosis with significant pain is also spontaneous osteonecrosis, which actually now has been linked to the root tear. And it is basically an insufficiency fracture, and even the name has been changed to insufficiency fracture. So this is him after 1 year, where things has not changed at all, and he is happy with the result that the pain that he used to have has disappeared completely. Still, he has the arthritic type pain, which is minimal, not causing him any issues. Another case, this is a lady who was 70 years old when we did this for her. And again, there are some changes, arthritic changes there, but not significant looking at this X-ray. So again, here in this case, both ways you can say probably we could have just treated this conservative, but she was in a lot of pain. We thought we tried the conservative treatment first with injections, but she did not respond to that. And then we went for the reattachment of the medial meniscus root, posterior root, and her mechanical symptom pain has improved. Now, did not go back to normal like before the tear, but that catchy mechanical pain has disappeared. Now, the outcome of this repair, sorry for this busy slide, but there are multiple papers basically which has shown that the progression of osteoarthritis was evident in those who underwent meniscectomies within 5 years. Within 5 years, they went to knee replacement compared to those who have had reattachment of the meniscal root. Also, another paper which showed that those who had repaired, they did not show progression of arthritis at 3 years. So in general, if you feel a joint line, the joint is not very badly arthritic, and like even grade 2, sometimes grade 3, where you feel this patient from the presentation point of view will benefit from this, definitely go ahead and do it. So what do we need? I'll just go through the things that I normally use for this procedure, and then show you the video. So you will need a scorpion needle. This is a must, and something to pass a suture with. This is the suture passer to pass the loop to retrieve the threads that you have repaired the meniscus with, a periosteal elevator, and of course a mallet, and you need the anchor to fix the repair extra-articularly transtibial through the on the tibia. Okay, now also you have to know your anatomy and the landmarks. You don't want to go off the attachment, because that basically like few papers have shown that misplacement or repairing it in the wrong position does not give you the same result as putting it anatomical. Okay, so put your anatomy in mind. So this is a video of the previous case that we've just discussed earlier, the young lady, 37, and we'll just go through the procedure now. So this is showing the medial side. Now I'm trying to do medial collateral ligament bicrusting to open up the joint medially to allow access. You can see now the space has become bigger. Then I would go for preparation of the bed for the root. And here you need to be careful. You don't go really the attachment. I mean, the PCL is right there, so you need to be careful. And then use a periosteum to kind of create a nice bed for the meniscus. All these steps just to help it heal at the end of the procedure. Okay. So periosteum was done, and then shave whatever is scuffed tissue being left there. You can see a raw bone there exposed. Of course, that's probably, if you go there, that's two way in. Then you go for the, you use 2/0 fiber wire and get 2 threads. Basically, I use, and I've learned this from Dr. Sultan Qaboos. Okay, so you've taken the first loop, and make sure that they loop, you make a loop with them, so when they pass, they lock. And that's one also locked there. Then you use a tibial aimer. I forgot to tell you about the tibial aimer. So the tibial aimer is essential part of this procedure. And here you have to identify your landmarks and know where exactly this is going to come through. You can see the drill is in there now. Then we switch with the thread passer, suture passer. Okay, so we need to retrieve now the thread out. Now the thread is out. We loop the sutures, the fiber wires through, and we bring it through the tunnel. and we fix it through the anchor outside. Of course, there are different techniques. The other way you can do is 2 tunnels and repair outside through over a bony bridge. Another way of doing it is using suture anchor, using high posteromedial portal, and you need to anchor the repair into the attachment. But that's quite technically demanding, and but this one is I find it easy to do. Okay, so after the repair, post-op rehab, non-weight bearing for 6 weeks, the range of motion exercises in a safe zone of 0 to 90 degrees for 6 weeks, then full weight bearing to start after that. Avoid basically deep squats more than 70 or praying on the normally, or sitting cross-legged the usual way on the floor for 6 months after surgery. So in conclusion, meniscal root tear is a serious problem that needs to be addressed promptly to avoid quick progression of osteoarthritis. Suspected in middle-aged women overweight with no history of trauma. Examine the MRI yourself. Don't rely on the report of the radiologist. Okay, the outcome is good, excellent after this procedure if done for the right indication. Root repair slows down the progression of osteoarthritis at the end. So that is the end of my presentation, and thank you very much for listening.
Thank you, Dr. Mohammed. It was a really informative lecture. You go step by step. It's like instructional course in meniscal repair. We now open the floor for any question. Just open your mic and ask your question. Dr. Mohammed?
Yes.
I have a question. What do you suspect the incidence of such trauma in our society?
I would say it's quite common. I would say, like when I say common, it is more than what we think it is. Okay, do we have an exact figure? Of course, we don't. But I am sure there are a lot of patients who come to us when there is already advanced arthritic changes in the knee, mainly the medial compartment. And at that stage, we don't normally go for an MRI, but I am sure if we look into these images, probably we might find an answer if these patients have got medial meniscus root as a cause of early medial compartment OA.
What about lateral compartment, lateral meniscus?
It is not that common. I have not come across a lateral compartment root, lateral meniscus root tear. We've seen that in traumas, but in degenerative tears, that's I have not come across, and it's very rare to have it in the lateral meniscus, and this is due to the nature of the anatomy, that the lateral meniscus is more mobile and it adapts for more like movement, so it does not go into that stress that the medial meniscus go through.
Yes, our president, thank you for joining us. We want questions also, or any comments. Dr. Hood, Dr. Sultan.
May I have may
Yes.
I ask a question?
Yes,
This
please.
is Ahmed Al Ghaithi.
Yes, Ahmed, go ahead, please.
I'm Ahmed Al Ghaithi from SQU.
Then
So,
Dr. Hood. Okay.
So my question to Dr. Mohammed Al Mutani, thank you first for the informative presentation. But what is the natural history if we don't repair it? So, like if we compare repairing or not repairing, so in terms of progression of osteoarthritis, and in terms of the limitation of the range of motion after meniscal root repair.
Okay, so most of the literature will say about 30 to 50% of the patient within 5 years, they will go for a total knee replacement if you don't repair. And now this is not talking about, this is only the end result as a replacement. Now the other fact that we need to address is their pain and their mechanical symptoms. The mechanical symptoms is significantly improved after the medial meniscus root repair. And in one systematic review, they reported that actually there is no progression of like 85% of the population who underwent root tear. There was no progression at 3 years. So if you repair it, you're slowing down the progression of the disease. If you leave it alone, then you're just leaving them with pain, mechanical symptoms, and the end result is osteoarthritis needing a knee replacement within 5 years.
Thank you, Dr. Ahmed. Or you have?
Can I just?
Yes.
Yes, just. But to Dr. Mohammed again. So you said it's not only about the progression of osteoarthritis, but also about the pain and the mechanical symptoms. But see patients who were advised for meniscal root repair, they started with the pain and the restriction of the range of motion, but they refused the surgery. And eventually they gained their range of motion and the pain a little bit subsided. So if the surgery is mainly for the progression of the osteoarthritis, this is convincing. But in terms of pain and the range of motion, I'm not sure. This is only my observation in 2 patients I have seen.
With regard to if we leave it alone, will their pain improve? The acute pain, yes, will improve, but they will continue with pain afterwards. And as the arthritis progresses, their pain gets worse. Now, I'm not sure how far you followed those patients, but in general, their problem most likely will just progress with time. And they will go into remember, this is just probably, we still don't know whether this is the cause of arthritis or it is the arthritis causing this tear to happen. And probably the most likely reason here, it's a degeneration of the structures. Part of the arthritis, we get this root tear. Okay. So to answer that question, yes, they might improve for some time, but that pain will come back again as the arthritis progresses. And our aim here is to address progression of arthritis as well as helping with the mechanical pain. Now, I agree with you. You will say that this mechanical pain might not be a major issue it can resolve, but if you can achieve both, then that is the best.
Thank you, Dr. Ahmed. Dr. Hood,
May I speak, please?
please go ahead.
Thank you, Dr. Mohammed, for the nice presentation. Really, I enjoyed it and very informative to me. I would like to ask about the failure rate in young patients. Is it high, low? And what is the effect of repair? I mean, if not repaired in young patients? Because as you said, the total knee from 30 to 50%. This is, I think, in old patients, isn't it? So
Yes.
in young patients, is it the same? What is the case in young patients?
Well, see, I don't have data to support a specific age group. Most of the data that we have is in the middle age, like in the late 40s, 50s, and they seem to, their progression of arthritis seem to slow down significantly. And remember, we're not talking about the majority of root tears are degenerative, but in case of traumatic, then most of the time it is accompanied by some ligamentous injuries like ACL or PCL. Okay, so when you address that, you have to address also the root tear at the same time.
Okay.
Because that is more important than the stability, and having the stability and the root, the outcome is very good.
And the learning curve to repair, because it has different methods, and does it need long learning curve? Or we can like practice, see if you practice then under supervision, or what do you think?
Well, I think you will need about, see, what I find is every case is slightly different, of course, but you will need about 5 to 10 cases until you master the technique and do it properly. But it's not about rushing yourself. Just take your time with it and identifying. If you are able to access the medial part, I mean posterior medial and posterior part of the knee, then you should be able to do this procedure. And there are techniques, you've seen that the MCL by cresting helps in opening the joint space and for you to go in without causing any damage to the articular surface, and also to allow you to put your guide in also. So it's about creating enough space for that in that area. But otherwise, there is a learning curve, no doubt about it. But
can I use suture passer, suture lasso? Sorry.
Yeah.
Instead of scorpion.
Anything that can pass suture through. Suture lasso is another way of doing it. You don't have to have the, if you don't have the scorpion needle, you've got the lasso, you can pass lassos, sutures through the posterior root.
And you prefer doing loop?
And if you don't have the anchor, you can tie it over a bony bridge, okay, using two-tunnel technique.
Okay.
And if you have got only a button and you want to use one single tunnel, then you can tie over that button, provided that it is bigger than the tunnel itself, the diameter of that button, I mean. So the idea is you pull it through the transtibial and fix it with whatever ways you feel is appropriate. I came across people putting screws and tying it over a screw. So yeah, so there are different ways of doing it.
Thanks, Dr. Mohammed. Thanks.
Any more questions?
Yes. Thank you, Hood. Khalid Al-Harthi, please go ahead. ولا يسلم علينا خالد. سليمان الهميمي تفضل.
Okay, thank you, Dr. Mohammed, for the presentation. Just one question. When you can decide that you are going to detach the root and repair it or shave it in cases of complex tear at the root? Because sometimes you feel like it's complex and shaving will not help. Thank you.
Sorry, I did not get this question, Sulaiman. Can you elaborate more? Sorry.
Sometimes I find the tear is very complex.
Yes.
So shaving will make it very thin.
Mm-hmm.
Do you feel sometimes you feel like you better to detach it or attach it again with the root repair?
Okay, you mean it is the root itself? It is there is some associated complex tear extending to the root.
Yes.
Okay, so basically here I don't detach it. What I do is just reinforce it. So I will tidy up the meniscus and take stitches through the meniscus and reinforce it with the suture, rather than detaching it and putting it back again. Okay, because there is already an attachment there. You don't want to compromise that attachment. Okay, so just reinforce it with another sutures, like 1 or 2, using the same technique.
Okay, got it. Thank you, Doctor.
Thank you, Sulaiman. Khalid Al-Harthi, ما شاء الله أسئلة حلوة. Good questions. Anyone has a question? Dr. Mohammed,
Yes.
guess I have a question. If you go at the end result of knee arthritis, how many of patients who has undergoing total knee replacement or uni knee replacement with meniscal root tear?
I did not get the question. Sorry. Is it?
If we see the patient who are already went through total knee replacement or uni knee replacement, how many of them really they have actually meniscal root tear during intra-op?
Well, during intra-op, we I don't really examine. Just go and chop it off. But probably it will be interesting to know this from like going through the, retrospectively. But this is not a simple task to do.
Yes, because now the recommendation, don't do MRI for arthritis knee. And when this topics is come in our mind and you make good presentation about it, it was really amazing. It orient us more. So we'll think about that in any arthritis knee with the mechanical pain as well. Khalid, yes.
Dr. Salah, the point here, when do I request MRI scan? In any situation where I feel the story does not match just simple arthritis. Okay, like for example, the X-ray showing a good joint space, then and there's significant pain, localized pain, then you know that there is something going on at that area. So investigate it with an MRI scan.
Okay. Khalid, you are raising your hand.
Yes, Dr. Mohammed,
Please.
thank you very much for your very nice presentation. My question actually, it's have been asked already by in the previous questions regarding patients where they have symptomatic osteoarthritis, which is also proven in X-ray, but they fit the demographic which you mentioned, like a middle age, overweight, pain with deep flexion. Would you still consider to investigate for root tear in such patients, or you would directly consider them to be like not a candidate for repair, so we just manage them directly as osteoarthritis, no need for MRI and so on? This is my question, because we see many patients and we manage them as osteoarthritis. We don't even look for root tear if the X-ray is showing very clear osteoarthritis, medial compartment osteoarthritis.
Thank you, Khalid. I think the answer is this question is not a straightforward answer to it. It's a matter of assessment, overall assessment, again, case by case. Like, for example, do I have sometimes difficulty finding out whether I will need an MRI scan or I will not? Yes, I face this situation where I feel it's very obvious there is advanced arthritis, okay? In the advanced arthritis, probably I know my surgery will not gonna add anything, then I would go for just conservative management. Whereas if there is reasonable joint space, and there is some arthritis grade 2, even sometimes grade 3, but not very advanced, and a young patient, definitely I will go for an MRI scan and look for this pathology if it is going in that line. And remember, get the whole story and examination and the images all together. And then if it is related to the root tear, probably worth repairing this and protecting whatever is left from that knee, because again, it is a gray area here. If you ask different people, they might say, no, you will not succeed in getting anything in this patient. But others might think about it in a different way, think like, this is a young patient, you're not going to offer any replacement now. You might as well protect the joint for more time until this patient is comes later on for a knee replacement in their 50s, for example. Okay, so again, it's not a straightforward answer to this question.
Okay, thank you, Doctor.
Thank you, Dr. Khalid. Anybody has a question? I think almost Dr. Ali Kshub, last question.
Assalamu alaikum, everyone. Thank you for presentation. And I have one question. After COVID, we have a lot of list of operations that we should do in Oman. So you said after 1 year, there is a change in osteoarthritis. And many of patients I saw for example, one of hospitals in Muscat, government hospitals, for example, is just ACL tear. They said 2023, the appointment for the surgery. Maybe it's more hospital problem or Ministry of Health, but how you manage this problem? Thank you.
Right. Thank you, Ali. I think there's here a priority comes here where you have to prioritize your cases. I put ACL before this patient, or I take this patient as priority? Definitely an acute tear. This patients with medial meniscus root tear will take priority because you want to preserve the joint as much as you can. Delaying this to 1 year will not be something of benefit. Actually, the outcome will not be as good because the arthritis would have evolved. Now, the waiting list problem has been there even before COVID. Now, COVID had made it even worse. But again, we are trying to protect the joint from a major intervention. So I would give a priority to this type of pathology more than the other if you say meniscectomies or meniscal repairs or ACL and so on. Okay, but again, it's difficult to just put a statement out there that this would go before any other case. Okay, so at the end of the day, they are not as common as you would see, for example, in other sports injury, but you see them every now and then. So they will not really bother you, your waiting list, as much as other pathologies. So I would give them priority, definitely.
Thank you, Dr. Ali. Thank you, everyone. It was a really amazing topic, a wonderful lecture, amazing speaker and participant. Thank you, Dr. Mohammed, for giving a nice lecture for our society. And also, I want to invite everyone, after tomorrow, we'll start our face-to-face